And the reason why I think it's been successful in pediatrics is, as opposed to high-grade gliomas, these low-grade gliomas tend to only have a single genomic alteration. So they are much, much simpler tumors, and where that BRAF alteration, be it a fusion, is the only thing that's truly driving that tumor. So when you shut that down, the tumor shuts down.
Welcome to Target Cancer Podcast. My name is Dr. Sanjay Juneja. I'm a hematologist and medical oncologist, also known as the Onc Doc on social news media. And today I'm honored to have probably our first guest that actually lives on an island. In addition to that very interesting fact, Dr. Sam Blackman is heavily trained, but more, I think, admirably, heavily passionate about things all related to neuro-oncology. He has training in pediatric hematology oncology as well as neuro-oncology, and has been very formative in really helping understand the treatment of what is really thought of as a stubborn tumor type. One, because it's in the brain, and we talked about in previous episodes how things that are in the central nervous system are kind of in a sanctuary, and things don't always cross the blood-brain barrier, so that becomes challenging. And secondly, we also talk about how treatments traditionally usually, work on replication cycles, and that's cytotoxic therapy. So you injure the replication process and it can kind of melt away if it's quote unquote, high grade. But what do you do about the tumors that aren't necessarily as replicative, meaning that they don't turn over as fast? And then on top of that being, with the blood-brain barrier issue. If there's one person to be able to tell us about those things, it is Dr. Sam Blackman. So with that said, thanks so much for being here.
Oh, thanks for having me. That is a lot of pressure up front, but I'll do my best to meet that high bar.
That's right. If you'd like, I'd love to know, one, what intrigues you so much about brain tumor types? Is it just that they're challenging, or is it really what I would assume based on your nature? Is it the need and the population, especially with gliomas and low grade and the pediatric population? I'd love to hear a little bit about your enamor with such a challenging field.
It's a great question, actually. I don't know that it's one that I've been asked before, so thanks for asking. Believe it or not, it has to do with none of those things, although I've come to appreciate all of them in the years that I've been doing this. The reason that I actually really fell in love with neuro-oncology in particular, it traces its origins all the way back to the reason why I went into medicine, which had nothing to do with science. My undergraduate degree is in philosophy, and one of my most favorite subjects was a discipline called phenomenology, really trying to understand and rectify our understanding of brain versus mind. They are, in fact, two different things. You can have a brain without a mind. It's hard to have a mind without a brain. But there's a difference, right? You can't find an anatomic locus for the mind. We understand brain. So what makes the mind and all the manifestations of who we are, and how have people come to understand that over time, has always been something that's absolutely fascinating to me. And obviously, I think increasingly relevant as we move into this age of artificial intelligence, right? Where we actually will potentially have a mind without a brain for the first time. So, that was how I started my education, was in philosophy. And when I finished my undergraduate degree, I had this really remarkable realization. I realized that I was likely going to starve to death and be completely and totally unemployed, because as a philosophy major, there's very little practical applications of that other than staying in academia forever. So I fortunately came from a medical household. My father was a pediatrician, and I had this vocabulary that was deeply entrenched with me of medicine. And towards the end of my undergraduate years, I began to understand the intersection of philosophy and medicine. The field of medical ethics in the 1980s was really burgeoning. Questions about end of life and scarce resource allocation and all those things that were debated sort of in the late 70s through the early 90s. And that was, where I decided to apply my talents. I decided to go to medical school, not because of necessarily the science, although I did enjoy the science. But for me, there were fundamental questions about life and humanity that I could answer through a career in medicine. And as I progressed all the way through the preclinical sciences and my clinical rotations and sort of a PhD in the middle, one of the things that I really appreciated over and over again was just neuroscience, And when I was a pediatric resident, one of my very first rotations was in a step-down ICU for neuro patients, and saw a lot of brain tumor patients. And it was the combination of the acuity of illness, the neurological manifestations of either a patient's disease or the therapies that they've had or the surgery that they've had, and just the hard problems, as you mentioned, of trying to get medicines across the blood-brain barrier and make a difference for these patients. All of those things, plus the philosophical stuff, made me realize that this was the field that I wanted to work in. And I pivoted my career during my residency and subsequently into my fellowship to focus on neuro-oncology. When I went into drug development 15, 16 years ago, it wasn't with the thought of making new brain tumor drugs, but in the back of my mind, I've always, asked, how do we move the needle in terms of drug development for patients with brain tumors? It's very hard. And then when I started day one 6 years ago, the very first drug that we licensed in, the applications in pediatric brain tumors were clearly visible, and it was the first place that we moved. So it's fun that everything has sort of come full circle, starting off thinking about the brain from a philosophical perspective, being interested in neuro-oncology from a clinical perspective, and then carrying that all the way forward in drug development it created an arc to my life and career that I didn't expect.
That's incredible. I guess if we have time, I'd love to know if you believe in, universal kind of, celestial orchestration, so to speak. And I say that because I was also a philosophy major in undergrad, and then I got talked out about my sophomore, junior year. Still have a minor, was like 2 classes short of double majoring. But it is largely in part what brought me into something with life and death and the whys. So I would, I'm going to try my hardest to pin your conclusion, especially between the mind and the brain, because that is an elusive one that I've not been updated on. But with all that said, it's going to be hard to resist. With all that said, that is, from a general community oncologist standpoint, or someone that finished fellowship, half a decade ago or so, really a couple of the challenges is one, this protective, arguably evolutionary, mechanism of insulating and protecting, testicles and then the central nervous system that, keeps it fortified from other things that may be circulating in our blood, etc. But that same arguably evolutionary, bottleneck effect can also kind of prevent us from getting drug in. That's number one. Number two, we think about things that replicate quicker as something to quote unquote hack. So we like to kind of throw a wrench in the system, smudge up the blueprint, and then the architect gets the blueprint, says it's smudged up, it can't make anything, scrap it and throw it away. That's kind of the concept of injury to at least, replication of DNA when it comes to tissues. And two things that are, for decades long and still very effective are cytotoxic chemotherapy, which can destroy and throw those wrenches or smudge the blueprints. And then, of course, radiation, because radiation, too, will damage it and kind of have these inherent, systems of surveillance come in and say, whoa, this is bad, and scrap it. So really, from, again, me just being a layperson when it comes to this, it's just resection, which is kind of like, and that too, now how do we figure out how much we need the resection? And that's where I think artificial intelligence can help a lot, because we can query the behavior of tumors with a lot more variables than we had before, other than just something under a microscope. So I'm really hoping, children especially, or just as much parents, can get a better idea of kind of the behavior of something. But of course, it goes without saying that resection is challenging because it's in an intimate area and we have very well-defined pathways and that do different things. So it's kind of thought of, and I wouldn't dare say this on this podcast, especially for you, but it's kind of like, oh, nothing ever happens in that field, right? Like, because it's like, it's almost like people just throw up their hands and say, it's impossible, you just got to resect. But you wouldn't be here if you weren't the person to say, actually, I have an idea, right? So we had Santosh Kansari. I think he's up in the Northeast.
I know Santosh well. Yeah, we trained in Boston together.
Yes, yeah, he's delightful. I think neurons must be the coolants of this otherwise nerdy field. And there were a couple of drugs that he was excited about that I need to follow up with him when it came to at least the higher grade GBMs and some astrocytomas. Tell us, if you can, What are some other mechanisms or hacks that we can use or are exploring outside of that replication stuff to be able to kind of control these tumors and hopefully maybe even assess how important or threatening they are? Do we have a better idea of that even to give families?
Yeah, so maybe I'll step back and just real quick cover, I think, some of, in maybe a little bit more detail, some of the challenges, because I think you elucidated some of them. Traditionally for pediatric brain tumors, there have been three pillars of therapy. I told people that, pediatric neuro-oncology is easy because there's only three things that you can do, right? Surgery, radiation, and chemotherapy. And as long as you remember three things, you're going to be a pediatric neuro-oncologist. But all kidding aside, surgery is not always possible, and it is limited. If I was lucky enough to be able to go and watch people resect tumors, after a while, it's very hard. Everything is gray or bloody. And so trying to tell where the tumor ends and the normal brain begins is hard to do. You can't take wide exorbitant margins in neurosurgery. You've got a melanoma on your upper arm. You can take a good sized margin and you can approximate the edges of that wound, or you can graft it over or turn a flap or something like that. You don't have that luxury in the brain, particularly in the developing brain of a child. So surgery is going to be limited. Now, for pediatric low-grade gliomas, the nice thing is that there's about 20 or 30% of patients who can actually have what's called a gross total resection. And those patients will have a very low chance of having that tumor recur, maybe only about a 10% of that chance of having that tumor recur. So there are patients with pediatric low-grade gliomas who ostensibly are cured by surgery. And obviously some of the locations for those tumors are things that are surgically more accessible. You do tend to have a number of patients with low-grade gliomas that grow right in the middle of the cerebellum. And you would think that that would be a hard place to get to. It's actually a relatively easy place to get to, much easier than, say, an optic pathway tumor, where taking out that tumor would potentially render you blind in one or both eyes. And so surgery can make a difference and actually be the complete treatment for some patients. Others, a partial resection may be the best that you can get before you get into more eloquent areas of the brain or things that impinge upon function, be it motor or visual or cognitive. And then there are going to be some patients who've got tumors either intrinsic to the brainstem or exophytic to the brainstem where you're just not going to operate. So radiation, of course, is very effective for low-grade gliomas, less so for high-grade. It's a mainstay of therapy for high-grade brain tumors, but it's really effective for low-grade gliomas. The problem is, of course, that when you pass radiation through the skull to get to the tumor in the middle of the brain, you have normal brain on the way in and normal brain on the way out. Caveat being, if you use protons, right, you can get the pass-through on the way in, not so much on the way out. But because of the way that we deliver radiation and to cover the entire tumor, you're exposing a great deal of normal developing brain tissue to ionizing radiation. And the developmental results, particularly for younger children, although we've learned now that also includes children up to the sort of mid-teens, can be profound. Anywhere from devastating to really, impactful of executive function or memory over time. So we're not thrilled about radiation. In fact, it's moved to sort of a salvage therapy for many pediatric low-grade glioma patients. And then the last bit about chemotherapy or systemically administered therapies, you're absolutely right. We've got this evolutionary blood-brain barrier that has developed over many, many, many millions of years to protect the central nervous system from horrible things that we might have eaten when we were crawling around on all fours. Fortunately, we've learned over time what the biochemical determinants are of the blood-brain barrier, right? There are efflux proteins that pump substances out, and our ability to construct molecules that either inhibit or are not substrates for those efflux proteins allow us now to intentionally design molecules that target known genomic alterations in brain tumors and don't get pumped out of the brain. So the residence time within the tumor is longer. So some of the hacks or sort of mechanisms of action, which is the lingo that I use, that I think have been focused on over the last 10 years or so of drug development that we've now seen some success with, have been signal transduction inhibitors, things that block catalytically active enzymes that signal growth in the cell. For low-grade glioma, BRAF mutations and fusions have been identified over the past 15 years as common. About 70% of patients have them. And now we've got good targeted therapies that bind to those mutant proteins or those gene fusions and shut off signaling. And that, in fact, slows down the growth of these tumors or causes them to shrink. Other areas that people are interested in, and again, it's early, we've not quite seen success, but are molecules that inhibit the DNA damage response, right? So when you have DNA damage, your cells have a machinery to try to fix that damage. And if they can't fix that damage, then cells get shunted down apoptosis, programmed cell death. So by blunting, and you would think it's a little counterintuitive, by blocking the in a targeted way, a cell's ability to repair DNA damage, these cells, which have very disordered and disruptive genomes, can't attempt to fix themselves, and so they just give up and die. Those drugs, as monotherapies, as individual therapies, have not shown a ton of activity, but in combinations, either with other DNA damage repair inhibitors or other therapies, or potentially radiation for higher grade tumors, are things that are under active areas of investigation. The other thing that I think is really most intriguing is the use of cell therapy, in particular CAR T cell therapies, to sublimate or sort of go beyond the underlying genomics that drive brain tumors and basically say, if I can find cell surface markers that make brain tumors different than normal tumors in the brain, can I reprogram and target T cells against those brain tumor cells? And you might say, well, how do you get those T cells into the brain? And the nice thing is we have ways of directly putting them in there. You can put what's called an Ommaya reservoir in, which is basically a portacath with a tube into one of your lateral ventricles, and you can pump those cells in, and they will go on their own. They're hunter killers, and they do provide immune surveillance over time and the ability to go and, in theory, hunt down micrometastatic disease within the brain. So those three areas, I think, are really most exciting.
We pardon this interruption real quick. If you're enjoying this podcast or find it valuable for what we discuss and the education and how people see and think about cancer in general, we would very much appreciate a like, subscribe, and especially a share so we can bring that information as maximally and broadly as possible. Thank you so much for listening. It's true. I mean, people, one of the ways that we're getting around, we've had a few episodes talking about CAR T, is just kind of pegging, a wanted poster or a description of, have you seen this person call so-and-so? Like, you're doing that on an immune cell that you already know has been conditioned and serving you purpose to, go attack, bad players. And that's kind of a neat thing I've recently heard about, even with peritoneal and other things, where people are looking to see, can we take the thing that always does the thing of killing, bad tissues, and then actually kind of enable it or make it smarter and go find it. That's number one, super exciting. And that was the first thing I was thinking about. Number two, when it comes to impair its ability to repair, it kind of makes me think about BRCA mutations and how we use what's called PARP inhibitors. So if we know they're not linked properly, because of a BRCA, but they're at least repairing as sadly as they can in the one strand. If you block that process, is it a miracle, kind of drug? No, but like you said, in combination. And that's where, Sid Mukherjee, we were talking about the gene code, or Sid Mukherjee's book in your background, his kind of, shtick was like, it's going to be combination multimodality therapy, and the sequence of what you're doing and when matters. We had an interesting episode that doesn't really go to one of the ways you mentioned. They're basically looking at seeing, can we even hijack the metabolism? It's looking at alanine and the breakdown and kind of eliciting this protoporphyrin response by hitting this certain wavelength of blue energy.
Yeah,
so these are all things where I think when you're talking about the pillars of how things can actually, be quote unquote cured, or at least in a permanent remission state, it gets creative and crafty this way. Between those things that you mentioned, we also heard about, I think once very fleetingly, about also similar to what you were saying, rather than kind of blocking the security guards that take you out of the the backstage or the club. Like if you were to, get someone in with a fake bracelet, you still have these players that are saying like, oh, this is fake and getting out. That is what I think about when you say the efflux, the people that would kind of kick you out of the arena, hijacking those. Another thing that I heard to that point was also using vaccines that we know have properties in a virus that permit you to get central nervous, stuff. So like syphilis, for example, can be kind of attack the central nervous system. So we're like, well, how did they get into the club? What bracelet did they wear? And then trying to carry that on inward as well. Of those, what are the ones, or which one are you kind of very excited about? And is it something that's quote unquote monotherapy, or does it make sense to do a little bit of radiation, but hopefully spare, collateral damage by also accelerating with an addition or add-on?
Yeah, I mean, I think I don't know. Look, if I had a sense of what I thought was going to be the most highly active new emerging brain tumor therapy, I'd probably be wearing better clothes or a nicer tie or something like that. I don't want anybody to walk away thinking that this is easy. In fact, this is I think one of the last frontiers for drug development. And there's a number of reasons for this. These tumors, particularly high-grade tumors, are very deranged genomically. That is to say, if you had 100 different patients with 100 different high-grade gliomas, right, histologically, they're all going to look very similar in their microscope. But if you sequence those tumors and compare the genomes of the tumors, you're going to find that they are a big hot mess. And almost every one of them is going to be different in some way, shape, or form. If there was a single driver oncogene for high-grade gliomas in the majority of patients, in the same way, for example, that with melanoma, 50% of patients have a BRAF V600 mutation, right? Or EGFR alterations in lung cancer or colorectal cancer, or ALK mutations in a certain percentage of lung cancer. If there were one of those for brain tumors, at a high enough percentage, I think that we would be in a very different place. But the fact of the matter is, much like acute myeloid leukemia, brain tumor genomics are all over the place. So that's why I think that at the end of the day, what we really need, and what's most likely to succeed in the long term, I think we have to understand the technology is likely going to be for high-grade tumors, some type of therapy where the immune system does the dirty work, because I really do believe it's the immune system that can transcend the underlying genomic mess of some of these tumors and really focus on cell surface recognition that discriminates tumor versus normal healthy tissue. And our engineering of immune therapies continues to get better. We can create cells not only that recognize one surface marker, but actually require a combination of surface markers in order to trigger that immune cell activation. And as long as we can sort of come up with the right area code, right, for a brain tumor versus normal cells, then the better specificity with which we can target tumor cells and spare normal cells, because T cells don't mess around. Like when a T cell is determined to kill you, it is going to kill you. And so the precision of targeting of those T cells by creating those chimeric antigen receptors really to focus on a combination of things that say, all right, this is a high-grade glioma cell versus this is a normal neuron, is going to open up that therapeutic window and allow us to apply this technology, I think, with greater safety. Now, there's still a lot that we need to figure out in terms of sequencing, right? Are these things that you should give early in the course of therapy? Should you give them late? Multiply relapsed brain tumor patients tend not to live very long. They're, by that point, after a relapse or two, the tumor is growing very aggressively and the patient may not survive for the time it takes for those T cells to really make a difference. But there's been some intriguing work out of University of Pennsylvania and Carl June's group, intriguing work out of Stanford and Crystal Makel's group, and then up here in Seattle, Nick Patanza's group at Seattle Children's, with intra-Ommaya administered CAR T cells that I think is the beginning of a successful shot on goal for this therapy in these tumors. So that's what I'm personally most hopeful about, although it is a complex therapy.
It is, and I'm glad you mentioned the kind of the genomic toolbox, if you will, or characteristics. I've heard that more than once, and we've talked about it in the podcast, is how just not consistent it is, where you can sometimes kind of get an idea if somebody's French or German or American. Here, it's like walking to New York City and trying to assess where you are if you didn't know, the area. They're complicated, and therefore it's not something that's uniform or unique. And kind of two theories, that we talk about sometimes. One, Jason Fung and Thomas Seyfried kind of make the argument, well, these are all downstream of a pathologic neoplastic process anyway. So it's like if you burn somebody's clothes, they get a stain in it, they'll change to something else. That's a scary conclusion, but probably in some way true. And that's where the metabolic stuff, comes in. And then, of course, with truncal mutations, the concept of, okay, we see these things, BRAF, EGFR, et cetera, but are there things that occur sooner and earlier that should this kind of tree of different mutations and fruits, like, can we even get in a truncal aspect before the limbs even start to differentiate? The point is, whatever we can get, we'll take, right? I mean, that's right now where we're at, that's like great and ideal, but what can we do? And when you tell me, 70% or so are BRAF positive, that can at least tell you, hey, that's a pretty darn, if it's not the trunk at the root, it's still majority of the fruit, but being toxic. When I hear BRAF as an oncologist, at least in the adult world, it's just not good. One, if it's BRAF positive and in colon cancer, it's just generally more aggressive on the right side, embryologically. It just makes more of a challenge and kind of permits us to even use more drug in combination. And then, of course, melanoma, you kind of hope for it because at least it's targeted until the immune therapy came out and kind of changed things around. In general, is BRAF a prognostic, less than ideal thing? Or, I always talk about HER2 positive. So was HER2 breast cancer was less than ideal thing until now it is ideal because you can target it.
Yeah.
So I guess hopefully it's an answer that combines both of those things.
Yeah, no, I think that's exactly right. I think, for I'll maybe just talk about the area where I probably know the most, which is on the pediatric side of things. First discovered, actually it was a gene fusion that took an open reading frame called KIAA1549 and fuses it to the catalytic domain of the BRAF gene.
Hey.
The BRAF has two big domains. One is the catalytic domain that actually does the signaling work, and then the other is an autoinhibitory domain that basically keeps the catalytic domain in an off position. Right.
Mm-hmm.
So what happens is when you lose that autoinhibitory domain and you replace it with something that doesn't make any sense, the catalytic domain just does its own thing, right? That's how that fusion works. That was discovered in 2008. So that's just wild type BRAF just going on its merry way without anything to control it. And then a few years later, we discovered these V600 mutations, which everybody at that time then realized were in melanoma, also occur in pediatric brain tumors. And at the time, I don't think anybody recognized, because it was so prevalent, whether or not there was a prognostic difference. Now we know that the V600 mutation tumors tend to grow or recur more quickly, and the fusion tumors tend to recur a little less quickly. But to your point around HER2, the nice thing is it's actually now made this whole 70% of patients have a drug target. And the reason why I think it's been successful in pediatrics is, as opposed to high-grade gliomas, these low-grade gliomas tend to only have a single genomic alteration. About 10% of them have a second, but for the most part, they have a single genomic alteration. So they are much, much simpler tumors, and where that BRAF alteration, be it a fusion or a V600 mutation, is the only thing that's truly driving that tumor. So when you shut that down, the tumor shuts down.
Wow.
And if you look at the drugs that target BRAF, you can, or downstream, even in MEK inhibitors, you can see, nice rates of response across the board for things that target BRAF or MEK, because you're really talking about a single dependency for these tumors.
Wow. Well, so when we talked about the genomic variability or the, identifying by country, we don't necessarily mean driver mutations is that it's
Correct.
Just a ton of them. It's more, I think their adaptability, if I'm using the right word, for tools, because the tools are less differentiated. which makes it challenging, at least in adult brain tumors. But that is very interesting because, on the adult side, especially like, squamous cell or some of these like, quote unquote dirtier tumors that sometimes work better with immune therapy, that you have a whole cluster. That's what you see on the report when you see this positive, this, especially some of the bone marrow disorders over time, that are in the older population, use that sensitively, but you'll see a whole bunch of things that you sometimes say this is bad. That's very encouraging to hear that, at least as far as we know. Is it fair to say as far as we know it's only one, or have we kind of really assessed every single,
Well, I mean, there have been case series published of there's actually a really remarkable piece of work done by Cynthia Hawkins and her colleagues at the Hospital for Sick Children in Toronto that was published in 2020 or 2021, where this is the nice thing about Canada, because it's single payer and national health insurance and so on and so forth. They have the ability to go for every single patient, and this is, again, with pediatric low-grade gliomas of a bunch of different types, go back and get all the longitudinal imaging, because if you have a national health ID number, then all your MRIs are linked to the same thing. So they went and sequenced 1,000 pediatric low-grade gliomas and then looked at the different histologic subtypes and looked at individual genomically defined groups and said, what's your progression-free survival, right? And what's your overall survival? And they were also able to look to see, are there co-occurring mutations? And I would say for the most part, again, nothing's, as you know, nothing in medicine is 0% and nothing's 100%. But in many, many, many instances for pediatric low-grade gliomas, you have a single driver alteration in the majority of cases. Now that pattern, by the way, is not unique to pediatric low-grade glioma. If you look at Ewing sarcoma, right, or alveolar rhabdomyosarcoma, or embryonal rhabdomyosarcoma, or a number of pediatric tumors driven by fusion oncogenes, they tend to be the alpha and the omega, right? And this has been substantiated in laboratory studies. If you shut down that fusion oncogene, that fusion oncoprotein, it shuts down the tumor. And a lot of these, sort of weird gene fusions that drive pediatric tumors, you can trace them back. Some of the really fundamental work on this has been done with leukemia, where certain gene fusions you can actually detect in fetal blood samples, right? So something happens very early in development that breaks some type of stem cell or precursor cell, and over time that eventually becomes cancerous. So the work around, and particularly the MLL gene rearrangement that leads to some pediatric leukemias, they were able to trace that gene fusion all the way back into like fetal blood samples or placental blood samples. So telling you that it was truly an error in development.
Oh my goodness. And to that same point, and I understand it's not black or white, but please tell me that there's some things that you can trace back to an error that still has a chance of phenotypic expression. Like, are there people that have these fusions that don't end up having gliomas, as far as you know?
I don't know. It's a good question. It's like trying to prove a negative, right?
Right.
We tend not to do brain biopsies on normal, healthy people who don't have brain tumors. So It's kind of an unknowable thing.
Until AI or some kind of wearables are able to, I don't know. You don't even have circulating tumor DNA with brain cells, though, so that would be really challenging. What are some other things, if any, that, and I know that's a difficult question. Everyone's about cell phones and all this stuff, but we're talking about a pediatric age where you're not even using cell phones. Like, is there anything else that we can...
I don't know. Have you seen kids today?
Well, true. Mine are still under 8, so we've been... tablets, though, are a different issue. But Point being, are there things that are at all... Does it just randomness and entropy, or is it...
Yeah, it's a great question. When I was taking care of patients, this question would come up all the time, right? And parents would ask, and it really tugs at your heartstrings. I say this as a parent myself. I think, God forbid, anything ever happened to my daughter, who's now 17, and I think, barely qualifies to go see, barely wants to go see her pediatrician anymore. I think she's ready for a proper grown-up doctor. I think if anything happened, I would be second guessing and triple guessing myself as to, is there something that I exposed her to, and I think it's normal for parents to ask, because it's very hard for us to just accept the complexity of the world we live in and of our own biology, right? I mean, you're talking about billions of base pairs and things that can go wrong, and we're exposed to God only knows what environmentally, and trying to ascribe causality, right? It's so easy to just point to something and go, oh, that was the thing that caused it, as opposed to saying, lightning struck and it happened to strike our house. But the fact of the matter is, if you look at the rate of brain tumors that occur in children, right, prior to the widespread advent of cell phones and now the widespread availability of cell phones, not just here, but in developing countries, you would think that if it were something truly causal about radiation from a cell phone, we would see a hockey stick like increase in the number of, and the fact of the matter is we haven't. We've seen this sort of slow creep up over time, but we're essentially flat, statistically flat over time. So I don't know that there's anything that I'm aware of right now that I can point to and say is some type of exogenous factor, right? Any radiation from cell phones or microwave radiation from 5G or anything like that. I just don't think that there's anything really to that. Again, back to the point, hard to prove a negative, right?
All right.
But I think if you look overall at the epidemiology of pediatric brain tumors and how it's changed over time and all the technological advances that have taken place over the past 50 years, and the fact that the incidence and prevalence of pediatric brain tumors has really not changed appreciably in 50 years, for me says probably not a whole lot about the external stuff that's out there.
I mean, I think that the absence of relation is really the most deafening statement, and I think a very loud one that, God forbid if anyone's listening and asking that question. I mean, this is math we're talking about. If there's a causal relationship and you increase the diet, the fast food, whatever you've been told by somebody that maybe was impositional and unsolicited, you would see that trend. That's called a high power study. We have numbers, we have data, we have communication, and we would be able to recognize, and this is the same answer every time. So I hope that placates anyone that, maybe going through this, that unlike some other things where we don't know exactly what it is with colorectal cancer, but we have a lot of, ideas like, fast food, less fruit and vegetables, all these different things, microbiome.
Yeah.
This is one that you were saying, and that's what my research showed. It's just, there's just no real change. It's just that very, very small percentage, but hard to find a relational. So I hope that brings comfort. So when you're talking about, the BRAF strategy, the way I think about it is you have maybe one alteration. There is this theory for anyone that's listening. That's probably not even a strong one, but sometimes you invite or provoke something, and I don't mean this to be insensitive, but a toddler in a bad mood, if you nudge at it, it's just going to get worse in a way. Sometimes the thought is if you do radiation first to something, you kind of invite more escape mechanisms or nudge it to want to kind of develop other escape mutations or drivers in that setting. Is there any thought behind a strategy of don't nudge, attack what we know, especially singular?
Oh, for sure. For pediatric patients, for sure, without a doubt. I mean, I will tell you one of the things that I carry around when I used to take care of patients. It was without a doubt one of my favorite things to do. Absolutely, most favorite things to do, and was very deeply involved with every single family that I took care of, and even when I moved into drug development, continued to follow up on my patients just to know that they were growing up and moving on with their lives. One of the cases that haunted me was a young woman who had what's called a ganglioglioma. It's a grade 2 WHO grade 2 low grade glioma, and it was deep in her brain, so she could only be partially resected. And this young woman at the time had gotten chemotherapy. So typically for these things with some tumor progression, you get chemotherapy, and that chemotherapy was carboplatin and vincristine, and it's a well described regimen. It definitely has its toxicities, but you get it for about 60 weeks, and many patients, about a third of patients, will never need any additional therapy after that, and about 2/3 of patients will continue to have their tumors march on. And when I started taking care of this young woman, she'd gotten her vincristine and carboplatin, we were following her, and her tumor just started to slowly grow. And I remember very clearly, she was a high school athlete. She ran track. And her tumor, when it was starting to grow, would affect her times when she was running the events that she ran. And so we ended up trying some alternative chemotherapy regimens. She didn't tolerate them particularly well. And then ultimately the tumor continued to grow, and she ended up going and getting radiation and also got temozolomide, which is what's used for adult high-grade gliomas. And the thought was, well, if she wasn't tolerating these other chemos, maybe she tolerated this one in combination with the temozolomide, maybe that would be the end of the tumor. And she did fine for a while, but about 5 or 6 years later, her tumor recurred, but this time it had transformed into a high-grade glioma, and ultimately it was fatal for her in a course of about 2 or 3 years. And so we know that low-grade gliomas, if you can get patients to their early 20s, they will, in the vast majority of cases, undergo spontaneous senescence. So controlling the growth of the tumor until you get to your early 20s, and then they just stop growing. We don't know fully why they do. They just stop growing. But if you radiate them, you run the risk of introducing new genomic alterations that could cause them to transform into higher grade tumors. And so as a field, and I don't want to speak for every pediatric neuro-oncologist, and certainly with respect to my friends who are pediatric pediatric radiation oncologists, radiation can be an effective and, in fact, an essential tool for high-grade tumors. But I think in general, we've recognized that the risks of radiation early are very high for pediatric low-grade brain tumors, and that we bring that therapy to bear only if we've exhausted everything else. So right now, where the field is going is surgery where you can, chemotherapy, and targeted therapy for patients who progress on chemo. The questions that are being asked actually in clinical trials are, hey, why are we giving chemo? Like, if we know patients have a genomic alteration and we have a drug, why not give targeted therapy up front and save chemo for later? And those studies are actually ongoing right now. We should have the answer for a number of them in the coming years. And then I think radiation still remains a backstop for chemo and targeted therapy when it doesn't work. Because of that concern that you raised.
Yeah, no, it makes sense. And I'm glad that there's, some real world evidence to support something that could be dangerous, which is important. And when we talk about data all the time. And this also shows the complexity of cancers in general, because, when you're talking about targeted versus chemo, the way I think about it sometimes, if there's a high burden disease, like a non-small cell throughout the body, for example, and I want people to kind of hear this so they can appreciate the complexity of strategy and tumor type. If it's a lot of disease in the body, generally some think of it as cytoreduce with chemo as soon as possible, because you have variants of, tumors throughout your body. And we know that these things, especially if they replicate fast, they undergo alterations. We already said it's different than, gliomas that might just have one. You have, just have heterogeneity. And so it's like reduce the mutational burden and escape mechanisms, then maybe target. But here it makes sense. If something is very, it's a singularity or of a driver mutation, it seems like it's more uniform, number one. And number two, they're not something you could easily cytoreduce necessarily. Of course, there's a place for it. Or you can. You said, vincristine and platinum can do well. But I just hope hearing this, somebody understands, or, the complexity of why sharing a story with a loved one. I see it every day where somebody gets a little bit of doubt in their treatment plan and stuff because so-and-so had so-and-so. These are the things that we consider, how fast does it replicate and what do we have left on the shelf as far as how to play, I don't want to, use the word play insensitively, but how to strategize the best. Now, I learned firsthand, very humblingly, whatever the word is, in a humbling way, I learned that Michael Levin and Sid Mukherjee have very different opinions. Michael Levin, I believe, is at Pitt, and he studies all about, bioelectric escape and how you kind of get into this autonomous way of thinking because you don't feel part of the environment. So they kind of do inherently what they're supposed to do to survive. Sid gave us, has, at least at the time, and I'm speaking for him, impression that there's not necessarily a selection pressure if you were to use a BRAF targeted, therapy to push this cell to be smarter, right? Like its argument is they're not smart, they just replicate in a certain way. Michael Levin, was saying, no, there is such thing as selection pressure, at least on a bioelectric, protonic level, proton, electrons, etc., because the circuitry itself has kind of invitations for selection pressure and escapes when it comes to just keeping an environment healthy and well, in the same way as an amoeba or a protozoan, and these things, these inherent concepts of survivability, not on a macro level, but on a cellular level. All that in a very complicated and unnecessarily tangled way. Is there any concern or thought that using a targeted inhibition in any way does something possibly similar to radiation? My personal reading says no, it's not nearly the same concept. But
yeah, I certainly don't. Again, the targeted therapies in pediatric brain tumors, I can count them on one hand. And the number of years that they've been approved by the FDA, I can also count on one hand. So you're not talking about a lifetime's worth of data here for me to be able to make any strong statements on. And I'm not the type of person who likes to make strong statements in the absence of data. But I can talk to you from the perspective of sort of reasoning my way through this. I think we all appreciate the fact that in tumors, particularly those with P53 mutations and some degree of genomic instability, that inhibiting a single node of a signaling pathway invites the potential for clones to emerge with new mutations that may allow them to work around and develop resistance. I think we can all also accept the fact that cells are cells, and cells exposed to some type of xenobiotic, right, some type of drug or foreign substance, will work to try to pump that thing out, right? It's a principle as old as sort of our understanding of antibiotic resistance, right? Cells will eventually emerge tumors will eventually find a clone that pumps the drug out effectively, and then that clone will grow, and then your tumor will recur as something that's resistant. And we see chemo resistance, and we see targeted therapy resistance. I think, at the end of the day, it's impossible for me right now to tell you whether or not in low-grade gliomas, almost all of which are P53 wild type, right? So they don't have that genomic instability. They tend to be actually genomically quite stable, and they don't replicate particularly quickly. They just sort of grow relentlessly, but maybe not that high Ki-67 high replication rate. So you're not making new clones all the time. That, the time that it takes for a cell to potentially become resistant is longer than the time horizon during which you're expected to undergo senescence and the tumor stops growing, right? So it's a little bit of a race, right, between pressure for the tumor to survive and then pressure for the tumor to shut down due to this intrinsic senescence program that, again, we can't prove, but we see over and over and over and over and over again, such that we think that it's true. Now, we'll have to obviously continue to watch this over time. For targeted therapies, there are always patients who don't respond. No drug is 100% effective. Why those patients don't respond, I don't think we have a full grasp of. It's very hard to do research biopsies of patients who don't respond to ask, what is it about your tumor that made it not respond? It's hard to do that in children. It's hard to do that in anybody, particularly in the brain. So we'll try to continue to get information wherever we can, or try to derive information from, radiographic features of tumors, or try to look for predictors of non-response, and then work backwards and try and figure out what's the biology underlying those tumors. But in terms for targeted therapy for low-grade gliomas, I remain confident that, resistance is likely to be futile.
Love it. And that's why I just love when you say, and then work backwards and see, that's where I get very excited about machine learning, deep learning, data science, is where really things that, if we're humble about the capacities of the human mind, just feed a bunch of variables, pharmacogenomics, sure, metabolic health, everything you could think of, and just let high computational processing power. And again, some will be bogus, like, it's just with people that eat bacon for whatever reason have like a 3x, fine, scratch it off, like, not top of priority. But that's where I think where some people kind of are binary about AI, where I think it can just have huge, jumps when it comes to our understanding, albeit CNS tumors, as I'm saying that out loud, probably be one of the more challenging ones because of the lack of variability, circulating tumor DNA, hard to access.
Wow.
I mean, there's just so many factors that would make it hard to get enough data.
Well, maybe just to build on that point, I mean, this is where I think it becomes important for us as a community, both on the academic side and community oncology side, on the drug development side. If we want to see a difference in our lifetimes in the survival rates for high-grade brain tumors, both adult and pediatric, then we do, in fact, need to move past the, this is too hard sort of phase of things and actually work in a concerted way to gather as much data as possible. One of the sort of badges of honor for the field of pediatric oncology, there's many, but one of the badges of honor is that we tend to put a ridiculously high percentage of patients onto clinical trials. In fact, in almost all instances, when I was training as a fellow, even if your patient was getting standard of care leukemia therapy, you would enroll them on an institutional clinical trial to be able to capture that data. And so there's an ethos within the world of pediatric oncology, which is every patient is unique and special and should be studied on a clinical trial wherever possible. And I think if we want to really mount a successful attempt to make a difference in high-grade brain tumors, we need to start treating, and patients need to be willing to contribute to this enterprise by enrolling on clinical trials. We need to get tissue or circulating DNA from cerebrospinal fluid if possible, but we can biopsy brain tumors, and the amount of information that we can get out of relatively small amounts of tissue is enormous. But not just getting biological samples. I actually think improving and collaborating around how we analyze radiographic data. And this is one place where I am very much a fan of machine learning, letting computers look for patterns across large, petabytes worth of radiographic data, and then correlating that with gene expression data or mutational data or RNA expression data to begin to understand, all right, these tumors that look like this and behave like that are associated with these genomic changes or genetic changes or protein expression changes. It's only once we begin to really change the way that we think about classifying brain tumors into a more of a molecularly defined framework can we then more efficiently begin enrolling patients on therapeutic trials that target those sets of alterations. But we really do need to work together to generate as much data as possible here. It's, if anything, my cry from the mountaintop to really standardize this research framework.
Yeah, I sigh almost like when speaking to that concept. It's for anyone listening, it's like, okay, yeah, you could do kilograms or pounds, meters and inches. Like, we need to speak the same language. We need to share it. We need to analyze it, and that I just don't see living in a capitalistic country, here, like that. It's so unfortunate. But my personal goal, is to explain really what the implications are. Should we be able to do that? How much accelerates things? Yeah. Now, all that said, if you have 30 seconds, I would love to know, Dr. Blackman, what is your in real time thought currently between the brain and the mind?
I've spoken about this publicly. If anybody in your listening audience listens to the Moth Story Hour, Moth Radio Hour on NPR, I've told a story about sort of my view on all things spiritual, and my sort of experience with that. At the end of the day, I'm still something of a reductionist. I think that my mind is a phenomena of a program running on my brain. By the way, I enjoy it very much. I love living inside of my mind. But do I think that is separate from my brain? Absolutely not. I am the first to admit that, everything that makes me who I am and the way that I perceive and think about things is ultimately reducible to some very, very complicated understanding of my biology. And obviously that's changed over time. It's hard for me not to think about the, hopefully, billions or maybe even, many billions of cells that are sort of packed into this little, 5-pound lump of jelly in my head, and not think that there's enough complexity in there to manifest all of the aspects of who I am and what I feel and what I think. And the same's true for you and everybody else. But do I think that there's something beyond the biology there that is my mind separate from my brain? Probably not. So I am, that is why to some extent, I look at, our quest to create an artificial intelligence as not something fantastical. I don't know that we can engineer something on our own that's as complex as what's evolved over many, many, millions and millions of years, to create this type of CPU that we have. But I am really intrigued by the possibility of taking the relatively limited CPUs that we have, which are pretty remarkable, getting them to learn and then watching them evolve way faster than, right? I think in silico evolution is going to be way faster than in vivo evolution. And I think it'll be absolutely amazing to see what happens once artificial intelligence, even rudimentary artificial intelligence, starts finding a way to improve upon itself to create things that could make the CPU better, to make the software better. But yeah, no, I'm pretty much on the biology side of things.
No, I love it. I mean, one thing that always stuck with me that still bothers me at 3 a.m. is the story of this, and there's many of these, that this judge, just do-gooder, amazing person, community person, et cetera, did a heinous thing, but I don't even want to say all out, found to have an aneurysm in just that same circuit that decreases your inhibition. And we know when you nuke that out, that it causes this kind of, heinous thing, or the foul personality with the story of the railway thing.
Phineas Gage. This is Phineas Gage. If you go to the library at Harvard Medical School, they've got the railroad spike that went through his head.
Thing.
It's a real thing.
And the judge with the aneurysm, they took it out after they served the sentence and stuff. Everything was fine 6 years. Did the act again out of the blue, repeated the scan, and the argument in court was, we know this. This is a heinous act. We know, we're not saying otherwise. And, the beloved community members were all like, whatever, empathetic. And to me, it distills down everything you were saying to that, because it's like the mind that people knew versus the brain that we saw change the behavior was inarguable. And there are many of these stories. I think some of them purposely kept under wraps, but it's,
what I tell my daughter is that brains get hangry, minds don't.
Oh,
my mind would not get hangry. My brain for sure gets hangry, right?
Yeah.
You don't feed me, my thinking goes, I can feel it. I can feel my personality change if I go too long without eating. And if my mind was just my mind, independent of my brain, right, I would probably not feel hangry.
Yeah. On that note, I don't know if you have a minute, but ketones, do you have anything on that? We know that it does with, seizures and things. Does it have anything to do on tumor growth?
I'm not an expert. The last time I thought about a ketogenic diet was when I was trying to lose weight quickly, but no, and I remember when I made myself full on ketotic, and I was like, I felt like I was hungover for days. Like, it took a while for that to sort of fuzziness and brain fog and whatnot to clear. No doubt, right, that being ketotic does something to your biology. Whether or not there's therapeutic benefit to that, I'm absolutely not the expert to say. I'd be way out over my skis.
Well, GLP-1s are out. I don't know if you've heard, but they kind of work easier.
I've heard. Well, I'm really trying to get there on willpower and sort of, behavioral modification. It's mostly, that's why the snacks behind me is that bag of oranges and not a big tray of jelly beans, which is hiding in the cabinet below.
There you go. All right, Dr. Blackman, we appreciate you so much. This was amazing, and I can't wait to see what you have left in store. I'm sure it's a lot, and we deeply appreciate your passion.
My pleasure. It's great talking to you.